Good afternoon. Hello. Feel like I haven't done one of these for ages. So you're going to have to bear with me a bit if I start waffling randomly because you know what I'm like. So the first one of these videos that I'm going to be doing for you today is on COPD and pulmonary rehab. There's also the other video on cardiac rehab. Obviously, if you're watching them the wrong way around or the other way around, I suppose there's no right or wrong way around to watch them. You'll probably get a same welcome on the beginning of that, also pointing you to look at this one. So yes, obviously the last couple of weeks we've been looking at different causes and different illnesses and injuries. Obviously last week we looked at cancer. Hopefully you've already done a bit of a recap on the anatomy and physiology of the respiratory system. I will be touching a tiny bit on that, but obviously I'm not going to re-go over the anatomy. That's you going back to your notes or back to your information from last year. So have a look at your anatomy textbook, have a look at your anatomy notes from last year on the respiratory system. Familiarise yourself with some of these bits, some of the anatomy on there, especially if you are going to be looking at COPD, asthma, or any other respiratory illnesses or diseases or issues for your assignment. So when we think about COPD, what is COPD? So COPD is chronic obstructive pulmonary disease, and obviously it's an umbrella term really for any kind of issues with the respiratory system. So it tends to cover things like chronic bronchitis, emphysema, anything that's going to cause an issue with the airways, with problems with actually being able to breathe, being able to get oxygen in. So obviously we've got a little diagram here of our respiratory system. We've got our trachea, our bronchi, our bronchioles, our alveoli. So when we're thinking about COPD, we're not concerned so much with the diaphragm or diaphragmatic breathing or issues with that. COPD tends to be more concerned with the actual airways themselves. So thinking of down from the trachea into the bronchi, the bronchioles and the alveoli. What kind of problems do we have here? Is it something like bronchitis where it's an inflammation of these different airways? Or is it something that's more like emphysema, which is actually damage to the alveoli sacs themselves, which causes a reduction in the surface area? So instead of having lots and lots and lots of little broccoli-shaped alveoli sacs at the end of our bronchioles, these sacs have started to disintegrate. They've got a lot bigger, which is obviously going to have a reduction on the surface area within our lungs, which is going to cause gas exchange and all the other things that hopefully you've researched and refamiliarized yourself with. And it's going to have obviously long-term effects on our body's ability to get oxygen in and then also to get rid of our carbon dioxide. Some of the things that can actually cause COPD are obviously smoking. I'm not saying that smoking hundreds of cigarettes at once like that chap is doing up there, but obviously long-term smoking can cause irritations to the airways. It can cause people to develop chest problems, emphysema, things like that. It might be that we've had environmental exposure. Has a patient been working in a particular industry or area that has exposed them to smoke, that has exposed them to different bits and pieces? Obviously this leads on to our bottom picture here, where we've got exposure to fumes or particles in work. Again, there are a lot of our patients who may have worked in certain areas or been exposed to different things which have caused them to develop chronic lung conditions, which are falling under the umbrella of COPD. Some patients, unfortunately, also have genetic predispositions or inherited conditions which have caused them to have, as it said, chronic emphysema, chronic inflammation of the airways and other things. So again, it's some of our patients, they might feel quite bad for thinking about holistic care being lumped into patient with patients who may have smoked or some of these things may be more self-inflicted. However, some of these conditions that come under the umbrella of COPD can be caused by genetic or other inherited conditions. So I'm thinking about our patients. Obviously, the first thing that our patients are going to do is they're going to need or want to have some form of diagnosis. So obviously, diagnosis can be quite hard when we're thinking about patients. You know, they've got to feel willing to come. They've got to think about, you know, what's going to happen to them. And it's really important that us as practitioners are there to support our patients through these particular journeys. So chronic respiratory diseases tend to become diagnosed by a combination of many different things. So obviously the first key thing is a detailed clinical history. Is this something that is as long term? Have they been seen for it before? Have they got a history of asthma or bronchitis or other respiratory illnesses? I suppose thinking about very contemporary issues, you know, is, you know, long COVID. Obviously, we don't know what's going to happen with our patients who may have developed long COVID or other lung-related symptoms after having COVID. So these are things that obviously we might have to think about going forward in the future. There's probably going to be a lot more research and a lot more investigations into whether these long COVID type symptoms may potentially at some point end up under the umbrella of COPD type issues. Again, you know, it is something really interesting. And if you are picking COPD or respiratory illnesses for your assignment, you might want to think about, you know, is this something that is going to affect or going to come under that umbrella in the future? So obviously a detailed clinical history is going to be the first key thing for any practitioner to undertake to figure out, you know, what is going on with this patient. Then the patient might undertake spirometry. So again, obviously on this diagram, this is quite a fancy spirometry meter where it actually shows the full spirometry reading on a computer. I'm doing that because it goes up and it looks like a little leaf or a sideways teardrop, which is going to show our practitioners, you know, what's going on. Is this patient having trouble getting the breath in? Is the patient having trouble getting the breath out? Or where are other issues within their breathing cycle? And then it might be that the practitioner is also recommend sending the patients for either just chest x-rays to make sure that there's nothing untoward, that there's nothing kind of serious hiding around in the lungs or within the chest cavity that could be causing the underlying respiratory problem. Or they might have CTs or MRIs or a combination of all of these things. Because obviously we need to be treating our patients, we need to be thinking about what these underlying conditions are. Before we start to think about, has our patient got COPD, we need to make sure that we're ticking off all the different bits and pieces to make sure that there's nothing a little bit more dangerous underlying, that there isn't any cancers, that there isn't any other issues hiding in the respiratory system or the lungs. So main symptoms that patients might present with tend to be things like a cough. Obviously, nobody wants to have a cough at the minute. Again, we're thinking about our COVID patients. We're thinking about what's going on in the environment at the minute. You know, there is a lot of research and there's a lot of discussion about, you know, how many patients are actually missing out on diagnoses at the minute because either they're scared to be seen or they don't want to bother their GPs, or they're putting them down to other underlying health conditions. And obviously cough, breathlessness, a wheeze, phlegm production, these currently are very, very much tied to our expectations of COVID symptoms. And there is a lot of research at the minute that shows that actually our patients that may be developing COPD or may have other underlying respiratory illnesses either may be getting diagnosed with COVID type symptoms, especially if obviously they have picked up COVID as well, or not wanting to approach the GP because obviously we're told, you know, don't go to the doctors, get yourself a test. And these are things that could actually hinder the diagnosis and treatment of our patients as we're going forward. Obviously, recurrent chest infections is another one that needs to be investigated. It's another one that needs to be looked at. You know, what are the reasons for this? Is there any underlying conditions? What's going on within the patient's respiratory system which could be causing recurrent chest infections? Is it due to fluid in the lungs? Is it due to other bits and pieces? Or is it due to the patient not being able to take those deep breaths properly because of irritation or blockages within the airways? So obviously this is going to go back to our previous slide when we're thinking about what are the diagnosis tools, you know, how are our patients diagnosed? So this is where the kind of clinical history is going to be the key thing, you know, then taking it forward to these particular tests to see which are going to be the best things to actually get that definitive diagnosis for the patient. There is a little video within this presentation. Now, I'm not going to show the video here, but I am going to put the link to the video within our Teams page. And this is kind of just talking you through what might happen to a patient who has COPD, what the reality is for them, and how it might affect a patient on a daily basis. So it is a really interesting thing to look at, just to help you see, you know, what your patients might be going through within their personal life and how COPD may be affecting their activities of daily living. So if we're thinking about the effects of COPD, and hopefully you'll all go and watch that video afterwards, as I said, I'll pop the link on. You know, what are the effects of COPD? How does our chronic respiratory diseases affect our patients? Obviously, I suppose the first key one is you can't breathe, or you have that feeling that you can't breathe. So obviously that's going to cause the patients to have a lot of fatigue. They're going to get worn out. You know, if you think about how you might feel after you've done some exercise, you're struggling to catch your breath, your respiratory rate's up, you know, you're really having to struggle to get those breaths in, you know, just for that short period of time after you've done that exercise, or doing exercise if you're somebody like me. But if you think that that is how you feel all the time, just the action of breathing, you know, we think about our COPD patients or patients who have respiratory illnesses, you know, we're talking about involvement of the accessory muscles up here. You know, we think about normal breathing as being diaphragmatic. We breathe from the diaphragm. You know, I know most of us tend to breathe from our chests, and we're not supposed to, and they're not very good. But, you know, if you've done any yoga, if you've done any meditation, if you've thought about anything like that, we're thinking about our diaphragmatic breathing, being aware of how we're actually using our respiratory system. When we're breathing in, pulling down from the diaphragm, expanding the abdomen, getting all the air down inside. And then when we're breathing out, pushing out from the abdomen, lifting up the diaphragm, and then expelling all the air. But if we're thinking about a patient who may have respiratory effects or respiratory problems or COPD, we're talking about patients who can't necessarily use that proper traditional breathing methods. So they're going to be using their shoulders, they're going to be breathing very much from up here. So you might see the patients kind of trying to take deep breaths using all these muscles within the top of the chest and the shoulders and the back of the neck, these accessory muscles, which we don't normally use when we're breathing traditionally. Again, think back to you after your exercise. You know, you're taking those big deep breaths because you're really struggling. You're trying to get that air back into your body. And this is what a patient with COPD or respiratory illnesses may have on a daily basis. So it's going to give them fatigue. They're going to feel exhausted. Also, the fact that they're not getting enough oxygen within their body, again, that's going to give them fatigue. Think back to, you know, why do we need oxygen? Why is oxygen so important? We need oxygen to be able to create our energy source. You know, think back to metabolism. You know, we only make a tiny bit of energy without adding oxygen into the mix. When we're thinking through our metabolic processes and we're thinking about the Krebs cycle and oxidative phosphorylation, we're thinking about we need that kind of inject of oxygen within the mitochondria for them to be able to create high amounts of energy. And if we haven't got that oxygen within our body, our mitochondria, our cells, can't create energy at that cellular level. You know, this is also going to give our patients low moods. They're going to feel depressed. They're going to feel fed up. They can't necessarily do their normal activities of daily living. You know, they might not be able to do exercise in the same way. They may not even be able to do their normal, you know, just a bit of pottering or going to the shops or little bits that they may have once wanted to do. So obviously this is then going to develop from the low mood. They might get anxiety, they might get depression. This then might cause them to have weight change if they can't be as active or do as much exercise as they used to do. And obviously when we start to put all these things in together, it's then going to affect them on an emotional and a social level in a lot more ways. You know, patients might start to lose their libido. They might not feel like they want to do anything, and we're starting to really get down the anxiety and depression way, not just because they're scared because they can't breathe, but also because of how COPD and other respiratory illnesses are actually going to affect them on that personal level. So what's the management of COPD? Obviously, the first thing is our diagnosis. We've just discussed how our patients might go through the diagnosis pathway, what might happen to them, how they might actually achieve an appropriate diagnosis of COPD. Then we're thinking about things like medical optimization. Does our patient have to be on any medication to actually support them with this? Is it something that they need to be taking inhalers or steroids or something to get that inflammation within their airways down? How can we actually support them from a medical side? You know, think back to your other modules. You know, we've done the medical model of health and we've done the social models of health. And it's really key that we put these two models, or we think about the biopsychosocial model of health, which encapsulates the patient holistically. So we have to have our medical optimization, but our patients might also be referred to something called pulmonary rehabilitation. And this is going to support our patients to actually manage their breathing, to manage their respiratory system in a way that may teach them new breathing techniques or relaxation techniques. I will talk about this a little bit more as we go through the presentation, but this is also part of that holistic treatment of our patients. Our patients may also need oxygen. Obviously, this is kind of a last stage effect. You know, hopefully we between our medical optimization and pulmonary rehab, we should be able to support our patients and get them back to a place where it might not be their traditional, you know, where they want to be. But we have to think about, you know, what is achievable and what can be expected for these patients. But some patients inevitably at the end of the day end up needing oxygen therapy for either part of the day or all of the day to actually help them manage their COPD and actually kind of get to that point. Obviously, we've also got to think about, you know, we've got to support our patients through palliative care and end-of-life care. Again, COPD might be something that patients are living with for a long period of time, or it might be that COPD or some of the respiratory illnesses that are coming under the umbrella of COPD are actually part of an end-of-life plan for the patient. So again, it's how we can actually support that patient through that and actually help them, again, get back to some semblance of something while they're in this palliative or end-of-life treatment period. Just excuse me for a moment while I have a drink. So obviously I introduced pulmonary rehab earlier. So what is pulmonary rehab? Well, according to NICE 2010, pulmonary rehab is a multidisciplinary program of care for patients with chronic respiratory impairment. These tend to be individually tailored. So it might be that patients are taking part in specific classes or specific seminars or support groups, but depending on the individual, these will then be recommended to that individual in a specific manner. They're designed to optimise the individual's physical and social performance and therefore autonomy. Again, we can't cure COPD, but what we can do is we can actually try to get the patient to actually feel like they are in charge of their own care, that they're back in charge of their own life. And even though their life may have to change, that they are still in control of some of the options and things that they have that might form part of this treatment and care pathway. And it's also about physical training, disease education, nutritional, psychological and behaviour intervention. I can't speak today. So when we're thinking about this, not only is it the medical side, we're trying to make the patient as well as we possibly can, it's also about the psychosocial side as well. We're thinking about how can we give that patient back their autonomy? How can we put them back in charge of their own life almost? But how can we give them that education? You know, think back to your health education modules. Totally went then, my mind went blank. But think back to your health education modules. We're talking about, you know, patients can't make changes unless they have all that information. They can't make the decisions, they can't go with these changes and actually, you know, develop new styles of life or new habits unless they have all that information. So it's really key that a pulmonary rehab also gives them that information, that it gives them the training. It might teach them how to breathe in a different manner so that they're not using these accessory muscles, because patients can become untrained in the appropriateness of breathing. It sounds silly, but patients can, and if we can help them, again, you know, that'll help to reduce their anxiety, it'll help to reduce the fatigue. Again, educating them on this disease, if patients don't understand what it is, that can be quite scary, that can be quite frightening. So again, we're giving our patients that information so that they can be in charge of their own kind of lives and their own experiences. And obviously we can also support them from a psychological and a behavioural manner, but we can help them to see that they're not the only patients who are going through this. You know, there are other people who understand, and we can put them in contact with either support groups or other patients who are actually going through these things or understand what it's like to have to go through these things. And so then they can form, you know, friendships. Oh, Siri's going a bit mad there. And then they can form friendships and supports and actually feel that actually somebody gets it and somebody understands what I'm going through. So when we're thinking about who should be referred for pulmonary rehab, obviously they've got to have a confirmed diagnosis of COPD. You know, it's not ideally that patients should be referred for pulmonary rehab unless they actually have a diagnosis, because they can get lost in the system of pulmonary rehab where actually they have a different underlying medical condition and that may need more appropriate treatment for that particular condition. Obviously they've got to be functionally disabled by their respiratory disease. You know, if they can still live a normal quality of life and it isn't impeding them in any way, it might just be that they need to work alongside healthcare professionals and actually get some of that education and advice, as opposed to having a full pulmonary rehab program. They have to be cardiovascularly stable. I mean, we'll come on a little bit more into the cardiovascular side of it when we look at the cardiovascular PowerPoint. But obviously, if our patients aren't cardiovascularly stable or they've got any underlying heart issues, it might be that the heart issues are actually causing them more problems than the COPD or the respiratory issues. So again, it's really key that we have our patients being cardiovascularly stable. And they've got to be compliant with clinical management. Again, there's no point referring patients to pulmonary rehab if they won't actually follow management or treatment plans from their GP or specialists, because, you know, if patients don't want to follow advice that might help them in one way, why would they follow help and advice in another way? And it's about going back to that patient and looking at what are the barriers that this patient is experiencing that are stopping them from being compliant with the clinical management in the first place. Is it a lack of education? Is it that they don't fully understand what their disease or diagnosis is? And it's about really trying to see what is the reason that this patient isn't compliant, and working on that and with the patient and supporting the patient, as we said, going back to that health education, thinking about our stages of change models, because obviously if a patient isn't compliant with one aspect of their care, they possibly won't be compliant with any other aspects of the care. So it's really key that we look at what are the underlying reasons for our patients when we're thinking about compliance and non-compliance. So the aims of pulmonary rehab, we've got things like obviously increased exercise tolerance and functional ability, reduce or control in their dyspnea and disability, improving the quality of life, promoting self-management and independence, promoting long-term commitments to exercise, and therefore reducing hospital admissions and the costs to the NHS. I know it's horrible when we sit there and think, you know, at the end of the day, everything comes back to money. And it is really horrible to think that, you know, we might have an illness or a disease or a problem, but at the end of the day, it's the cost to the NHS. And while we might see that as a negative, we've also got to think about the fact that actually, if we can do all the others, if we can improve a patient's quality of life because we're putting this support, we're putting these different things in, if we can give them that self-management and that independence back, and we can increase their ability to get out for a walk, to go to the shop, to meet up with friends, to talk, these are all going to be really, really big positives for our patients. And they are going to also help the NHS at the end of the day. So the core principles of pulmonary rehab are progressive exercise. We're starting patients off with things that are manageable and developing them and supporting them in an achievable way with the support of healthcare practitioners. So that obviously if the patient gets into any form of distress while they're undertaking these exercise programs and they're progressively managing their exercise and getting that bit stronger and developing their skills, that obviously they've got those medical practitioners to support them. And it's also about, as we said earlier, self-management education. If our patients don't know what they're doing right or what they're doing wrong, they're going to keep on making the same mistakes, not because they choose to make them, but because they don't necessarily know that those mistakes are right, wrong, or indifferent. You know, we don't know what we don't know. And at the end of the day, if our patients don't know, they aren't going to be able to make those changes. So it's really key that we have that self-management and education, that we're going back to those stages of change models, that health education, and we're able to support our patients to become independent, to become autonomous, and we're giving them that information to actually support them through their journey. So the negativity spiral, when we're thinking about physical deconditioning, obviously we're all going through this at the minute. You know, if you've been one of those amazing people who have done Joe Wicks every day and love him and think, oh, I can't wait for my 9 o'clock Joe Wicks session. Wow, I bow down to you and applaud you. But if you're like the rest of us who said, lockdown number 3, I'm going to go to do my gym, I'm going to put something on YouTube, I'm going to get really fit and healthy, and then you sit there eating biscuits. You know, the negativity of inactivity spiral is really, really, really easy to get into. So if you're actually a patient who's struggling to breathe, who's really, you know, fatigued and starting to have some of those negative thoughts and feelings that we were talking about earlier, it's going to be really hard to actually, really easy to actually go into this negativity spiral. So again, if we have normal activity, that's where we want to be. But as we start to reduce our activity, we start to reduce our abilities to do things, we start to increase our dyspnea. We start to therefore increase our anxiety because we can't breathe more. We're really struggling again. And because I can't breathe, I'm now avoiding it even more, which then reduces my capacity further. So suddenly I'm going in this downward spiral of the less active I become, the less active that therefore makes me, and therefore the less I can breathe, the less I can do, and suddenly I can't do anything without being totally out of breath, because actually I've not been in this positive thing, I've been in this negative inactivity spiral. That, as I said, the thought of going for a run is just killing me at the minute, but I know I can't go for a run because I've not been doing any exercise. So if you think about that on a normal person's attitude, a person who really does have an underlying medical condition that is making these things even harder anyway, and they're really going to start to struggle. So obviously what our pulmonary rehab is trying to do is it's trying to put us into a positive activity spiral. Going back to Joe Wicks, fantastic man, but he's all about, if you do exercise, you're going to feel good. Exercise increases our endorphins. It makes us feel good. It makes us feel energized. It has really positive outcomes on the body. It helps us to sleep better. It helps us to do all these things. So actually, if we're starting to support our patients through an exercise program, we're starting them off with something very basic, maybe a chair exercise. Maybe it's something as simple as just building the muscles up so they can help themselves get out of a chair and back. And it's something very, very basic. But once they start to be able to do one, they can then do something else and then do something else. And this is really what we're trying to do. So then they're going to get reduced anxiety. They're going to get less avoidance. As they start to see they can do more, they're going to want to do more. Oh, look, I can walk to the end of the street. Well, now I'm going to see if I can walk to the bus stop, or I'm going to walk to the shop, or I'm going to do this. Suddenly, we become more positive about things. We become more able to do things. We avoid things less. And then your capacity is either maintained. If we've got to our patients to a level which is going to be their level, that is fantastic, and we can keep our patients at that level. Or we might be able to even get them a lot higher increased, or even back to our normal activity. And this is really the key thing. It's back to that education and support. If our patients are in the downward negative spirals, we're really going to struggle to get our patients back to a place where they want. And because they can't see that they can get back to a place where they want, they fall further down the spiral. But as our patients start to move up the spiral and they start to see more positive outcomes, they're going to want to move back up this spiral in a more positive manner. So obviously our pulmonary rehab exercise strategy, it's about endurance training for functional gains. We're not trying to build muscle. We're not trying to, let a patient run the marathon. It's about functional gains. If a patient's struggling to get up out of a chair, can we get them to a position where they're getting up and out of a chair? Can we get them to a position where they're able to walk into the kitchen and make themselves a brew? Can we get them to a position where we're giving them back their quality of life? We're going back to those, activities of daily living. What are our functional gains that are going to change our patient's life? And what might be a functional gain and the key achievement for one patient might be completely different for a different patient. And this is back to why our pulmonary rehab is a very individual thing. We aren't trying to say that all patients should be getting to the same place. What we're trying to say is that our patients should all have individual targets, and that is where we're trying to get our patients to, working with our healthcare practitioners to get them to that point. And again, our exercise strategy is also strength training for specific activities. So as I said, Are we helping our patients to actually be able to get up and out of a chair? Are we helping our patients to be able to walk up the stairs in a positive and supportive manner? So it's really, really important that, again, our patients are understanding why we're doing these specific strength training activities, that we're not trying to turn them into Mr. Muscle or get them, bodybuilding or doing anything like that. What we're trying to do is to retrain or to strengthen specific areas of their body so that we can help them to be able to do these normal, positive activities of daily living. And we're also thinking about our respiratory muscles. It's all well and good thinking just about maybe our cardiovascular health or thinking about our strength and our muscular health. But it's also really important that we're teaching our patients appropriate ways to breathe, that we're helping them to understand, this is how to breathe. If you're struggling to breathe, sit up, chest up, think, get yourself into appropriate positions. What's the best position for them to be lying in bed, or how are we going to support them to be in a better place for respiratory muscles to be working, diaphragmatic breathing to be working better? And these things will all come together in a really positive way. It might even be something as simple as teaching a patient appropriate inhaler technique. Again, the inhalers or the treatment might be working, but if a patient isn't aware of the appropriate way to use inhalers, and I'm sure we've all seen really poor inhaler technique out there, patients just going and that's it. You're not actually using your inhaler properly. These patients need to be taught to actually, take those practice breaths, get your chest used to actually being used before you take that, inhaled medication. Take the inhaled medication in the appropriate way and then hold it and then release it slowly. Again, we're trying to get that medication in. We're trying to get it into the airways. If you've done medicines management with me, we're thinking back to our absorption pathways. If all we're doing is we haven't actually given our medication much time to work through that absorption pathway. So the medication might be really, really good for the patient, but if the patient isn't using the medication appropriately, it's not going to be helping them to actually help that chest clearance or help clear up that inflammation within their airways. We're also thinking about self-management and education. As we said, health education is such a key thing whenever we're talking about any underlying medical conditions. And it's really key that we help our patients to know and understand the condition that they've actually been diagnosed with. If they don't understand what the different medications are for, they're really going to struggle with why it's important to take these medications. As we said on the last slide, if our patients aren't actually able to use their medications in the correct manner, they're not going to be getting the most out of the medications that they're taking. Do they know what's normal in terms of symptoms? Again, what are their normal symptoms and what might be a symptom that's over and above, or a new symptom, or might be a symptom of something else? That they can recognise when these symptoms are actually getting worse, so we can actually support our patients to say, right, at this point we now need to get further support or further medication or further guidance. That they know what to do when these symptoms are worsening. That they know who to contact and how to contact them when their symptoms are worsening. And they know when to call for emergency help. And they know what support is available and how to access it. We think that all sounds really obvious, but for a lot of our patients, and a lot of our patients who are dealing with COPD, our patients can tend to be older patients. They might not like to bother doctors and nurses because they feel that they're being a nuisance. They might not understand things, or they might feel that the doctors talk too quick or just thrust some medication at them, and they don't really understand why or what or how. So it's really, really key that we think about, making sure that our patients have all the information that they need to be able to make those informed choices, and that they know what to do if they need help. Obviously, we've got some lifestyle change strategies as well that pulmonary rehab is going to do. So we've got stress and anxiety management. Now, hopefully, if we're thinking back to our positives and negative spirals, we're getting patients into being able to do more. They're going to feel less anxious. They're going to be able to do more again. They're going to get fitter. They're going to get healthier. Breathing is going to get better. And hopefully part of that is stress and anxiety management. But it might also be a change in the diet. It might be supporting patients with smoking cessation if patients are still smoking. Again, making them understand and giving them that help and support to make those informed choices to actually stop smoking, which again, I'm sure you did all about when we did health education, and we did our stages of change model about, how to support patients with stopping smoking. That it might actually be our comorbidity risk assessments. So again, is there any other underlying health conditions that are actually going to make these patients' COPD worse? And can we actually get those treated or supported in a better manner? Making sure that the patient is aware of appropriate disease self-management, and supporting the patient with self-efficacy, that they can make their own choices, that they have all the information that they need to make the appropriate choices. There's also a couple of links to the Breathe program here. This is a really interesting thing to look at. If any of you remember Joy, she was part of this previously, so it is a really interesting thing to look. Again, I'll put the links on our Teams page. But I hope you found that really interesting, listening to me witter on about COPD. As I said, there is the cardiac one to watch if you've not watched the cardiac one. Obviously, if you've already watched the cardiac one and then come to the COPD one, well, you're fine. Have a think about this. Have a think about how these things might actually link. There'll be a couple of tasks on Teams to have a look at, ready for our discussion on Thursday afternoon. But, COPD is a really interesting thing to look at. So have a lovely day, and I shall see you all soon. Goodbye.